So good afternoon, everyone. Thank you for coming here today to learn about the work that we are doing on long COVID. My name is Helen Chu. I'm a faculty member at the University of Washington, and I study respiratory viruses. I first want to thank the Brotman Beatty Institute for helping to organize this seminar, and especially Jenny Logue and Zach Acker and Jasmine Dong for really putting this together. And I wanted to thank the sponsor, Alex McMillan, who provided the funds for this meeting. So thank you all for coming. So our group first became involved in long COVID research right around at the beginning of the pandemic, when we had set up a cohort of individuals who had been recovered from COVID-19 and were following them to really understand their immune responses to that early infection. And what we noticed, or rather Jenny noticed, was that people were coming in and letting us know that they were starting to experience brain fog and fatigue and trouble breathing and really being really tired after exercise, months after their COVID infection had resolved. And so that started our interest in our research in long COVID. And of course, now over the past almost 4 years, we've now come to understand a little bit more about long COVID and what it is. I think the most important thing is that we don't actually know that much. We know that it affects about 65 million people worldwide, that it leads to severe disability, and that it's really not just one syndrome, but actually a lot of different syndromes that seem to affect many, many different organ systems. What's frustrating, I think, for a lot of people who are experiencing long COVID, many of whom are probably here, is that we don't actually have a way to diagnose it. There's no clear lab test for it. There's no X-ray that shows that you have it. There's no way for us to really say that one person has it and another person doesn't. And we have no way of really being able to tell who's going to get better or who's going to get worse. And I think that's frustrating for all of us. What we do know is that there are some hypotheses. One is that potentially this is persistent infection, persistent virus that's triggering some of this, that there is an autoimmune element to this, or that there potentially is an inflammatory response that's driving a lot of this. But really, we're not sure if any of those are true. We do know that vaccines seem to prevent long COVID, that if you get a vaccine, you reduce your risk by about 30%. And there are certainly many trials going on looking at other possibilities of other therapeutics like Paxlovid or metformin, but those are all really ongoing. So really the point of today is just to bring together those of us in the field who are working on this. And I want to thank all of the speakers who agreed to come and speak to you today about the research that we're doing here in Seattle to understand long COVID. And really it is people from public health, scientists who work at the bench, and then doctors who are in the clinic. And I think everyone's going to come together and give you a 10-minute overview of what they are working on. And then we'll have time for a little bit of Q&A at the end. Afterwards, we'll have a reception upstairs, and hopefully some of the speakers can stay and answer some questions from others. And then I think there are a couple of just small housekeeping things, which are that if you are on Zoom, we cannot monitor the Zoom chat and have turned off this feature. So, but you can email us, you can email me if you have any questions about the things that you hear today. So what I'm going to do is go ahead and just introduce all 6 of the speakers now, and then I'll turn it over to them to speak. So our first speaker is Dr. Tao Kwan-Gett. He is the Washington State Department of Health Chief Science Officer, and then he serves as the primary science expert and a key spokesperson on public health. He joined the Department of Health in fall of 2021 and has more of than a decade of experience in practicing primary care pediatrics in Seattle. And also worked as a communicable disease medical epidemiologist at Public Health Seattle King County before joining the faculty at the University of Washington. Our second speaker will be Eric Chow, who is the Chief of Communicable Disease Epi and Immunization at Public Health Seattle King County. He's a clinical assistant professor in the Division of Allergy and Infectious Diseases and Epidemiology, University of Washington. And prior to this, he was an epidemiologic intelligence officer with the CDC, and really led a lot of our early work about trying to understand multi-system inflammatory syndrome in children and comparing flu and COVID hospitalization in adults. And I've had the pleasure of working with Eric in my group for a couple of years, and we're really sad actually that he left us for Public Health King County. Dr. Janna Friedly is professor of physical medicine and rehab and chair of the Department of Rehab Medicine at the University of Washington. She is a board certified physiatrist in the UW Rehab Medicine Clinic at Harborview, executive director of the UW Medicine's post-COVID rehab and recovery clinic, and the editor-in-chief of PM&R, which is the official journal of the American Academy of PM&R. And she conducts health services and outcomes research related to chronic pain and disability. Professor Gentile is assistant professor in the departments of family medicine and lab medicine and pathology. She is the primary care medical director of the post-COVID rehab and recovery clinic at the University of Washington and a practicing family physician and long COVID specialist. And her research centers around investigating long COVID related pain, including a clinical trial to explore acupuncture treatment. Dr. Jason Goldman is an infectious disease physician, epidemiologist, and clinical researcher, the focus on infections in immunocompromised hosts. He is predominantly an expert in solid organ transplant, but has actually done a lot of work in COVID in the last couple of years. He trained at Duke, University of Pennsylvania, and the University of Washington. He is currently at Swedish, is also a clinical assistant professor in allergy infectious diseases at the University of Washington, an affiliate investigator of Fred Hutch. And he has done a lot of work in collaboration with Professor Heath on understanding the immunologic underpinnings of long COVID. And our last speaker will be Dr. James Heath, who is the president and professor at the Institute for Systems Biology in Seattle. And he has had a profound impact at ISB since taking over the leadership in 2018. Prior to that, he was at UCLA. At the beginning of the COVID-19 pandemic, he really pivoted to work to understand the factors driving long COVID and published a very important paper looking at cohorts based here in Seattle to understand the four main factors that drive long COVID. So hopefully he'll be able to speak to us about that. He has a lot of awards and honors, and then has co-founded or founded several companies, which I didn't know about. So thank you to all of you for coming to speak to us today. I'll go ahead and turn it over to Dr. Tao Kwan-Gett, and one of us will be sitting in the front and holding up your sign to keep time. Thank you.
Thank you, Dr. Chu, and good afternoon, everybody, and thanks for the opportunity to participate in today's seminar. I'm going to give the Washington State perspective on long COVID. And let's see if I can get these slides to. See. Okay, great. So I won't really talk much about what is long COVID. You'll be hearing a lot about that from other speakers. I'll talk a little bit about why long COVID is difficult to measure from a surveillance standpoint. And I'll talk a little bit about how the Washington Department of Health estimates the burden of long COVID in our state. This is actually done by a lot of people who are a lot smarter than me, who use terms like Latin hypercube sampling. I have no idea what that is. So if any of you have any technical questions about their techniques, I won't be able to answer them. But I do hope to give you a little bit of a flavor of how we generate these estimates. And then I'll talk a little bit about why a public health approach to long COVID, especially a public health approach that emphasizes the social drivers of health, is so important. So as Dr. Chu mentioned, long COVID is really an umbrella term that probably encompasses several different syndromes. And there are a number of reasons why long COVID is difficult to measure. Though acute COVID-19 infection is a notifiable condition, long COVID is not. So a notifiable condition is a disease that's required by law for healthcare providers and laboratories to report to their local health jurisdiction. So as we know, not everybody who gets COVID-19 tests or gets diagnosed with COVID-19. The impact of long COVID is quite variable. It's not like measles that has a very predictable set of symptoms. One person's experience with long COVID and their symptoms can be very different from another person's, and that makes it difficult to count and assess. Not everybody who develops long COVID seeks healthcare. And even amongst those who do see a healthcare provider, not everybody gets diagnosed with long COVID. And rates of long COVID vary quite a bit by severity. So we know that those who've been hospitalized for their acute COVID-19 infection have higher rates of long COVID than those who are not hospitalized. And we'll talk a little bit about how rates of long COVID vary by age, race and ethnicity, and geography. So all of our notifiable condition data goes into a database called WDRS, which stands for the Washington Disease Reporting System. And it's this database through which numbers are crunched to generate our dashboard. So we used to have a COVID-19 dashboard on the health department website, which has since been replaced by a respiratory illness dashboard. But we pull data from WDRS to populate this long COVID model that I'll talk about. And basically, we use what's called a compartmental model, which means that we consider all of the population as being part of one of several boxes. And we start off with considering the boxes of people who have COVID-19, that's a box on the lower left, as well as people hospitalized with COVID-19, that's the box here on the lower right. And we actually use the number of hospitalized cases to also give an estimate of the number of unreported symptomatic cases of COVID-19. From the scientific literature, we know the rates at which people who are not hospitalized go on to develop long COVID, and also rates at which people who are hospitalized go on to develop long COVID. And then similarly, we get estimates from the literature, the rates at which people with long COVID, whether they got from hospitalization or not, either recover or go into the unrecovered box. So imagine people flowing between these different boxes, and that we simulate those with a computer, and that's how we develop these numbers. And then we we run this model using several different layers, layers with age groups, eight age groups, 5 different race and ethnicity groups, 2 sexes, 3 status of vaccination, and 39 counties within our state. Now you can see that there's a lot of missing data in our Washington disease reporting database. Where for example, race and ethnicity, 42% of cases in WDRS have missing race and ethnicity data. So when we see this, we use the median value for a particular demographic for this model. So what does this model tell us? It tells us that long COVID does significantly impact the lives of many Washingtonians, and there are perhaps 107,000 Washingtonians who live with significant activity limitations from long COVID. And this is based from data that was updated in December 2023. We estimate that that adults in younger age groups, adults ages 18 to 59, have higher rates of long COVID than either children or older adults. And you might be puzzled by this, as I am. We had mentioned that rates of long COVID are higher in people who are hospitalized. We know that older adults have higher rates of hospitalization, so why don't they have higher rates of long COVID? Well, there are a lot of different theories. We don't really understand. We don't really know for sure. It's possible that younger adults are more likely to survive their acute COVID infection and go on to develop long COVID. It's possible that adults in the younger age groups are less likely to be vaccinated than older adults. Possibly younger adults, because they are working and in school more than older adults, practice less social distancing, and maybe practice less social distancing for the intention of protecting themselves from infection. So it possibly could be a combination of factors that leads to this difference. We also estimate that females have a higher burden of long COVID than males, and other speakers may have more insight on this. I believe it's possibly due to differences in inflammatory response and the immune system response between women and men that account for this difference. Those identifying as Black and those identifying as Hispanic or Latino also have higher rates of long COVID. And we know that race does not have a genetic basis. And so often when we in public health see differences by race, we think of the social drivers of health and how they are influencing differences in disease rates. And I'll talk about that in a moment. We also see that the prevalence of long COVID is estimated to be higher in central and eastern Washington than in western Washington. And again, there are many potential reasons for this. So in this map, those counties with higher rates of long COVID are shaded in red, and those with lower rates of long COVID are shaded in blue. So we do know that these counties in central and eastern Washington have, on average, a younger population, so that could be part of it. We also know that these areas of the state have lower vaccination rates, so that could be part of it as well. And it could be that the social drivers of health, again, have a powerful influence. Before the pandemic, if we were to show a map of life expectancy or of chronic disease, the map would look pretty similar to this, actually, where poor health is experienced by many communities in central and eastern Washington. And there are a number of reasons why this might happen. Often we think of the social drivers of health as being very powerful influences on different rates of disease in populations. So education, access, and quality, we know that those who have higher education status are more likely to be vaccinated. Healthcare and quality, if you have more access to healthcare, you're more likely to be vaccinated and more likely to have access to antiviral treatment. Neighborhood and the built environments, if you live in a place that has grocery stores more handy and more opportunities, parks, bicycle paths for physical activity, you're more likely to have healthy eating and active living, which decreases your risk for chronic conditions and long COVID. Social and community context, we know that racism, stress, trauma increase one's risk of chronic conditions, and that could increase the risk for long COVID. And then economic stability, we all know that poverty impacts all of these, and that poverty comes with a higher risk of chronic conditions and lower rates of vaccination, more difficulty accessing healthcare. So what this means is that the really important scientific advances in long COVID are so needed. But unless we really are mindful of the social determinants of health, the social drivers of health, it's possible that any new therapies that are developed for long COVID could exacerbate inequities rather than solve them. You can imagine if there was a treatment that was only accessible to those who were wealthy with privilege and not accessible to those with less privilege, how that could serve to exacerbate inequities in long COVID in our state. So just to recap, the burden of long COVID is high and appears long-lasting in Washington state. There's a lot of variation that exists by demographics and geography. This long COVID model that has been developed is very promising, but further refinement and validation is needed. And a public health approach that addresses the social drivers of health is really important if we're going to approach long COVID equitably. So that's the end of my slides. I just want to thank all of those at the Department of Health who work on the long COVID model, particularly Aaron Hamlet, who's one of our CDC epidemic intelligence officers who really spearheaded the modeling work on long COVID. And that's the end of my slides. I have some spare slides that we can come back to if needed. Otherwise, I'll hand things over to Dr. Chu, or hand things over to Dr. Chow to speak next. Thanks.
Right. Oh, it's a really young picture of me. Need to send an update one. All right. Well, thank you so much for the opportunity to be a part of this afternoon discussion on long COVID. And I'm really excited to be here to be able to give this presentation. Specifically, I would like us to kind of pivot and focus over to the public health priorities and challenges related to post-COVID-19 conditions, as well as COVID-19 in general, which of course are intricately connected. One of the things I wanted to point out early on was kind of how our mindset and approach towards COVID-19 has evolved over the pandemic. And I really tried to dig into our internal archives and think back on some of the newspaper headlines that really made us aware of the health impacts of COVID-19. And I think back at this media headline that I saw published in NPR, where Tony Fauci was estimating that about 100 to 200,000 people in the US would die from coronavirus. At the time, I was thinking to myself, wow, that is astounding. That is horrific. I hope we never get to that point. But fast forward to 4 years later, we see a mindset change that even though the CDC is now reporting that at least 6.7 million hospitalizations as of January have been reported to them due to COVID-19, as millions, almost 1.2 million deaths due to COVID-19 have been reported, people have really been feeling that inertia to move towards and put COVID-19 behind them. And that's a real challenge for us here in public health about how to continue to put COVID at the forefront of everyone's mind to ensure that people are taking the precautions, especially as they're especially as they're reverting back to pre-pandemic behaviors and activities. And one of the focus areas for us in public health has been trying to integrate the post-COVID-19 condition or long COVID component into our messaging, highlighting for people who otherwise may not see themselves as vulnerable, frail, or in older age groups, which would be risk factors for acute illness severity, but would be still at risk for post-COVID-19 conditions. And so oftentimes people then ask me, as I'm integrating this into messaging, well, what exactly is the burden? What exactly is that magnitude? And as Dr. Kwan-Gett mentioned, this has been really difficult to measure, and a lot of different models have been proposed to be able to get to that. And here I use a very quick and dirty back of a napkin kind of model, just estimating based off the number of COVID-19 cases reported to WHO, which we know is an underreport of the total number of cases globally, and use a conservative measure of just 10% of people who go on to develop a post-COVID-19 condition. Even with that, we arrive at a very startling number, 77 million people who have had post-COVID-19 conditions or continue to experience them now. And again, we know that this is likely an underestimate of the true burden internationally. And when you pair this up with people's experiences, the actual health burden that people go through when they have a post-COVID-19 condition, this situation is magnified. This is not simply a minor inconvenience that people are experiencing, a minor symptom, but signs, symptoms, and conditions that are incredibly debilitating that completely change a person's perspective and ability to kind of even get through life. And even from an economic perspective, we see this impacting people's ability to get back to work, to be able to do the same level of work that they did before. And some estimates comparing some of the costs associated with clinical phenotypes of post-COVID-19 conditions to ones that are similar to chronic fatigue syndrome. We know that there's going to be significant healthcare costs. And some organizations have even estimated that here in the US, that as of January 2022, there's been a substantial economic burden placed on our country as a result of this, hence why this remains a public health priority. And admittedly, we're still early in our discussions as we're continuing to uncover and contribute resources to researching this. But one of the biggest hurdles that we face right now is really the fact that this is a diagnosis known by many names. For some of you in the audience, you may be more familiar with the term long COVID. For others, you may be using post-COVID-19 conditions, a term that WHO, CDC, and Infectious Diseases Society of America have moved towards. And also the NIH Recover study has also historically used the past definition. And with each of these names comes different definitions too. And so as you can imagine, when people are trying to understand results and compare results between studies, it's been a real challenge. But fortunately, the National Academies of Science and Engineering and Medicine have started to convene work groups to try to unify a diagnosis and to draw upon people's lived experiences of having long COVID and be able to integrate this into a living, evolving definition. So more to come on this point, but a lot of efforts have been to try to bring us all together to be able to compare apples to apples. But in terms of truly understanding, based on the available data, what the true burden of COVID-19 is, I thought that Dr. Eric Topol's team did a really good literature review published in Nature's Review of Microbiology to try to summarize all the available data that's out there on post-COVID-19 conditions and be able to provide these ranges of prevalence of different post-COVID-19 conditions by different patient groups. And they found that in their literature search that between 10 to 30% of non-hospitalized cases go on to develop a post-COVID-19 condition, 50 to 70% of hospitalized cases, and 10 to 12% of vaccinated cases go on to develop post-COVID-19 conditions. And Dr. Kwan-Gett also alluded to this, but one of the other important points that I really want to try to emphasize, and I emphasize every time I talk about post-COVID-19 conditions, is that we know that the pandemic has exacerbated racial and ethnic disparities when it comes to infections and just health outcomes. And even though we haven't fully elucidated that yet for post-COVID-19 conditions, we know that from our experiences at the height of the pandemic, that when compared to white populations, Black and Hispanic populations have increased rates of SARS-CoV-2 infections and increased risk of hospitalizations due to COVID-19. And the combined elements we know also should put people at increased risk for post-COVID-19 conditions. And this is an important area of research that we need to commit resources to. Even just some early data has also already shown the importance of ensuring that at least in our study participants represent a diverse group of individuals, that if we are to only include white populations in our research studies, that we may be missing the full spectrum of clinical presentations associated with post-COVID-19 conditions. And just early publications from people's experiences in terms of ensuring that there's access to post-COVID-19 condition clinic resources, we're seeing disparities as described in this report by this one clinic's experiences. But fortunately, over the last couple of years, we've made substantial progress in terms of papers that have put together really nice public health messaging that has highlighted the importance of ongoing integration of lessons learned that we should be taking away from the height of the pandemic. That is, of course, staying up to date with recommended vaccinations, integrating that along with layered approaches, wearing a mask in indoor crowded spaces. I'm so excited to see that so many people in this room are wearing high quality, well-fitting masks. And improving indoor ventilation, getting tested early and getting treated early, all elements that are really important to reduce risk of infection, risk of severe disease, and subsequent risk of post-COVID-19 conditions. And in these two studies here, it also emphasizes the reasons why, even though you've had COVID-19 before and you somehow managed to dodge post-COVID-19 conditions, the reasons why these layered approaches are still relevant to people's, are still beneficial to people for subsequent infections. And a lot of work has been going into understanding what ways people or what strategies people can take to help reduce the risk of post-COVID-19 conditions. A lot of focus has been on vaccinations. And I'm really excited to see all these publications published over within the last 2 years that have really highlighted that staying up to date with the recommended COVID-19 vaccinations does help people reduce the risk of subsequent development of post-COVID-19 conditions. But it's also an important thing to point out here that COVID-19 vaccinations alone is not going to completely reduce your risk of post-COVID-19 conditions, that we do need to take a layered approach, that in addition, again, to vaccinations, we should be focusing on masking indoor public spaces and improving indoor ventilation. A lot of interest has been put into, of course, also looking at treatment and the treatment's impact during acute COVID-19 and the subsequent development of post-COVID-19 conditions. And I'll say that this is an early area of research. Some observational studies have shown mixed results so far, but I think it's safe to say that any effort that you go into to try to reduce your risk of infection and reduce severity of disease at the acute stage is also likely to have some benefit at the post-COVID-19 condition stage. Now, as I summarize kind of my last few thoughts here, I want to leave you with an important message that I thought was really well articulated in this perspective article published in the New England Journal under the title, "Do Pandemics Ever End?" And they emphasize a really important point that I think is a key piece that we're really trying to emphasize in public health as people throw caution into the wind and try to normalize some of the health burden that we continue to see. And the only people that are going to be, or the people that are going to continue to be disproportionately impacted, again, are those people who have experienced historic inequities, especially during the height of the pandemic. And I want to read this because I think this point is really important, because people oftentimes ask me, well, when is the end of the pandemic? And I think that this summary here is really an important thing for us to all kind of think about when we're talking about this with other people about why COVID should still be at the forefront of our minds. And that is, the declaration of the end of a pandemic therefore marks a critical point when the value of a human life becomes a variable of actuarial significance. In other words, when a government determines that the social, economic, and political costs of saving a life exceed the benefits of doing so, it is neither epidemiology nor any political declaration that determines the end of a pandemic, but the normalization of mortality and morbidity by means of a disease's routinization and endemicization, what in the context of COVID-19 pandemic has been called living with the virus. And this is a message that really resonated with me and really helped me put into context kind of all the work that we're doing within public health, all the work that everyone's doing here within with regards to the clinical support and continuing to message the importance of prevention for acute COVID-19 that should subsequently also decrease our risk of post-COVID-19 conditions. So when people ask me what keeps me up at night, it's just that, is that people are going to throw caution to the wind, that people are going to let go of those pandemic lessons learned, this feel this draw to put COVID-19 behind them along with all those other lessons learned, when in reality, we should be really taking the situation seriously, knowing that with increased risk of acute COVID-19 severity, we're likely to also see increased rates of post-COVID-19 conditions. And that we already see some early evidence that what our strategies to reduce risk of infection and severe disease are likely also to help reduce the risk of post-COVID-19 conditions. And I consider myself very fortunate because I happen to be able to practice public health in a location where I think we actually do a much better job than most other places at putting COVID-19 at the forefront of people's minds. Emphasizing again, trying not to trivialize or normalize the death and the health burden associated with COVID-19. And again, I always say this because it sounds like I'm a broken record, but some of the same principles that have been so helpful to us to reduce our risk of subsequent complications associated with COVID-19 are still true today. And that is, of course, staying up to date with the recommended COVID-19 vaccinations and taking a layered approach, wearing high quality, well-fitting masks, indoor public spaces, improving indoor ventilation, getting tested early, and getting treatment when you're eligible. So I'll conclude there, and I'll take any questions towards the end. Thank you.
Thank you. Oh, no, I think we're fine. Great. Hi, thank you so much for being here this afternoon. I'm really pleased to be here today. I am going to just spend a very quick few minutes talking about the clinical side of things and what we've experienced here at UW. And then I'm going to turn it over to my partner, Dr. Gentile, to talk a little bit more about the research that's going on in our clinic. So as we mentioned before, we founded this clinic very early in the pandemic. We started this clinic in May of 2020, right in the height of the pandemic, recognizing that there were many people being affected by post-COVID condition. And this clinic is a multidisciplinary clinic, and we partner with our family medicine, internal medicine, primary care colleagues, neurologists, rehab psychologists, and a wide range of specialists who help participate in this clinic. So over the last few years, we have seen thousands of patients in the UW clinic. I don't have time today to talk about all of the treatments that we're using in the clinic, and I know that there's lots of questions about what the most effective treatments are. I would just like to say that we currently don't have any one single treatment that's most effective for long COVID, but all of the research that you're hearing about today and will hear about in subsequent talks helps to inform potential treatment strategies. So we've got a lot more information about the pathophysiology and the different subtypes of long COVID and how it's affecting people. And all of that research is helping us to come up with treatment strategies for our patients. So I'll just share very briefly, over the last few years that we've been seeing patients in the clinic, we've learned a lot of things that I think are important. You've heard that there are over 200 symptoms that people experience with long COVID, and the treatment, the course for patients is very unique. So there are many overlapping symptoms that people have, but nobody has the same course. And although we don't have any one particular treatment for long COVID yet, I do think it's coming. But we have many different treatment strategies that we have been using in the clinic, and we've been helping patients to get better. I think a couple of things that are really important to know, and that I tell my patients, that COVID is like lighter fluid; it sets everything on fire. So when people have underlying medical conditions, premorbid medical conditions, COVID can exacerbate those and can tip people over the edge if they have any predisposition to medical conditions. So we have to think about things holistically. We have to look at COVID and the after effects of COVID in the context of all of the other underlying medical conditions that people have, as well as all of the psychosocial issues that people are experiencing, because that all influences how people experience COVID. I mean, I think most importantly, what we've seen in the clinic, and you'll hear a little bit more about this, is that patients are frustrated out there, and there's a lot of disbelief among the medical community about the presence and severity of long COVID, and so there's a lot of relief from our patients when they come to see specialists who understand it and believe them and are able to help them manage their symptoms. So I think the access to specialists in long COVID is really important for patients and continues to be very important. We use a very holistic treatment approach in our clinic, and I won't go into details about this, but I do think it's important that we treat the whole person and that we look at all of the different factors that are associated with patient symptoms, and that's where we have really seen the biggest benefit. So we do focus on the whole person when we're treating patients. I do want to just mention something briefly about access to care, and we heard earlier that in Washington State, there's over 100,000 patients that are affected, people that are affected by long COVID. We in the clinic here have had up to 17 different physicians at any given time in our clinic seeing patients, and we've only seen several thousand patients over the last few years. So we know that we are just skimming the surface in terms of what the need is for specialty care in Washington State and throughout the WWAMI region. We also know from our data that we are missing a lot of patients in those high-risk categories. There are many patients from underserved communities and underrepresented populations that are also not represented in our clinic. And so in response to that, in our experience, we applied for funding through AHRQ to improve the access to care within our clinic and throughout the WWAMI region to specialists who have experience with long COVID. So we were one of 9 multidisciplinary clinics around the country that were awarded a 5-year grant to improve access to care for patients. And really the focus of this grant is to not only improve the delivery of care and access within our clinic at UW for patients throughout the WWAMI region, but also to do community outreach and to train primary care physicians and other clinicians throughout the WWAMI region to be able to better care for patients in their own communities. We are focusing specifically on populations including Native Alaskan, Native American, South Asian, Latinx, and LGBTQ, as well as rural patients through this grant. So a lot of great work going on in our clinic. I'll just highlight that this is a very large team of people who are working on this and a multidisciplinary team. So I want to thank everyone who's here. Many of our team members are here in the audience today. So I'm going to turn it over to Dr. Gentile. Okay, great.
So I'm going to talk just a little bit about two specific studies that are ongoing in our clinic right now, both of which are supported by internal royalty research fund grants, and both of which have the data that has come from these has gone into either the AHRQ award proposal and also clinical trial studies that are up and coming. The first one I'm going to talk about is a randomized controlled pilot trial that is using evidence-based self-management strategies. Specifically, our rehabilitation psychologists are leading this, and they're looking at the feasibility, acceptability, and preliminary efficacy of the intervention, that, which is 6 modules of group sessions where long COVID patients can actually come together and they are taught specific skills targeting 6 elements to help them with fatigue, breathlessness, memory and attention issues, as well as sleep issues, and stress and anxiety. So this data currently is being analyzed, and they're hoping to submit for a larger clinical trial grant in the near future. And I can say just anecdotally, several of my patients have participated in these group sessions, not as part of this study, but just out of our clinic, and have really found immense benefit and actually wish that these sessions went longer or that they could repeat them. The second study I will talk about is another mixed methods study that is led by myself and my colleague Chris Ma and research scientist Rachel Geyer. And here we looked at over 1,000 clinic intake surveys along with patient reported outcome measures. And we did 7 focus groups with 25 patients. And altogether, we looked at the association pain may be having on quality of life and function, as well as patients' perception of the care that they're receiving for long COVID. We have a ton of results that came out of this, but I just want to highlight a few in response to some of the questions we received in advance of this symposium today. And that is that the majority of patients that we see are reporting moderate to severely impacted physical function, as well as fatigue. And there's a high level of depression, anxiety, and PTSD in patients with long COVID associated pain. What is even more remarkable, though, is that 9% of patients versus 0% of patients, 9% of patients with pain versus 0% without pain are actually reporting suicidal ideation or intrusive thoughts, which just highlights the importance of what the rehab psychology team is doing in the study that I mentioned before. We also received a question about workability before coming into this. And so I wanted to highlight that almost half of the patients that we're seeing are at moderate to high risk of prolonged pain and disability. And 81% of all the patients that we've seen in our clinic, so that's out of the thousands of patients that we've actually seen, are actually reporting that they are unable to work at the same capacity that they did before they had COVID. So this is very important when considering just the burden of long COVID on not just the patients, but the healthcare system and where we're going in the future with this. Regarding the qualitative work, several themes came out of this. I think it's important to note that what was discussed is primarily related to the perceptions of care that patients received prior to being seen in our consult clinic. But I do think that the themes are important for everyone to hear, including the public. And that is that patients are feeling like it's incredibly difficult to receive a formal diagnosis of long COVID. They think that there's an overall lack of awareness of the condition. There's lack of resources. Their treatments that are being recommended are not in line with their goals. And all of this is really impacting how they can move forward. And so we are about to publish very soon some clinical considerations coming from this, and that is that we really do need to be taking a whole person approach and caring for these patients holistically, and educating the public like we're doing now with symposiums and seminars. And I think it's really important. And from a system standpoint, improving the coordination of care. And above all, we need to be listening to our patients and validating their experience and involving their family members and them and everybody as a team and working together. So as I mentioned, some of this data went towards clinical trial grants. We do have some upcoming studies that are really exciting. We have an acupuncture grant for pain that will be happening soon, that I'll be leading, the Energize trial, which Dr. Friedly will be leading. And then our rehab psychologists are also going to be continuing their work. And then a new pilot study that will be starting soon on stellate ganglion blocks for anosmia, so we're all very excited about this. Lots to come, and there is hope. Thank you.
Hi, thanks to the organizers for inviting me here. There we go. I'm so happy to see a good showing for this important session. I'm Jason Goldman. I'm at Swedish Medical Center, and I've been doing a lot of work with some of the other panelists on long COVID research throughout the pandemic. Here are my disclosures. So just briefly in an outline for the talk today, I was going to focus a little bit on some of the hypothesized mechanisms of long COVID. Talk a little bit about the NIH RECOVER study, and go through a couple of the different proposed mechanisms. One of my favorites is viral persistence, and then talk about some of the newer or emerging ideas that are coming forth in some recent high-profile publications. This cover art was a illustration of one of our studies earlier in the pandemic that was kind of one of the first big deep dives into the biology of long COVID. All right, so I think this audience is aware of some of the symptomatology of long COVID, and it's already been described by different names. This is a study from Jenny Logue and Helen Chu early in the pandemic. That was kind of one of the first descriptions of the symptomatology of long COVID in the US. So, we see kind of some of these now well-known symptoms are common in patients who are in the post-acute phase, but not as common as they are in acute illness, of course. This is just an illustration of some of the different symptoms and how they kind of track across all the different organ systems. Neurologic is very prominent, pulmonary, cardiovascular, cutaneous, and then, of course, general symptoms, fever and rash. And it's important to note, as many of the other presenters have, just how the psychiatric overlay might be part of the long COVID syndrome or exacerbating the long COVID syndrome, but it's definitely intertwined. This was a picture from one of our patients in a observational COVID trial, and he was profiled in an article in the New York Times on long COVID for one of our earlier papers. He experienced quite a lot of psychosocial symptoms during his long COVID journey. He actually got this tattoo on his arm, which he told me all about the sort of terrors he was experiencing. So here's a cartoon about the mechanisms of PASC or long COVID. These are, of course, at this point, still all proposed. None of them are really proven. But we sort of see that there's lots of different potentially overlapping mechanisms. We'll talk a little bit about viral persistence, but this might in itself lead to a chronic inflammatory state. The inflammatory state could be also the result of other parts of this diagram here. For instance, the microvascular dysfunction. There's also some theories about dysbiosis or reactivation of other latent viruses. and autoimmune reactivities as leading to some of the symptoms that people are experiencing and reporting. So the RECOVER study. So this, I think, is really quite an enormous effort on the part of the U.S. government. I think somewhere between $1.2 and $1.5 billion have been committed to this effort. Here in the Pacific Northwest, we are, one of the sites, one of the hubs of this study. Jim Heath, who you'll hear from next, is the lead of our hub, and Helen Chu and I are also both sites in the hub. This is our landing page, and you can see some of the other organizations down at the bottom that are participating as part of our hub. So we've enrolled a huge number of persons to participate in this observational study. And really the goals of this study are to understand the pathophysiology of long COVID and to better explain the symptomatology and to define it better. So all of these efforts are underway within RECOVER. There's also another very important part of RECOVER, which is clinical trials, which is a little bit slow on the startup, but it has finally gotten going, and it's really exciting. And I'll talk more about this. But the RECOVER program really has quite an enormous infrastructure that you can see outlined in the slide. There's different components of the program that spans coordinating centers around the country. And there's clinical trials units, the RECOVER observational and rolling cohorts that I mentioned we're participating in here in the Pacific Northwest. And there's also big EHR systems that are being sucked in and able to be analyzed within the program. A whole different network of pathobiology studies that's going to try to get at some of the underlying hypotheses. And then separate pediatric study and adult study, as well as an autopsy study. So really quite an amazing infrastructure has been spun up in a short amount of time. I think it is a large effort, and there have been some bumps in the road. So it's been a little bit criticized in the media, but I think that really quite amazing things are going to come from this, if I had to predict. All right, so the first mechanism that I'll talk about briefly is this idea of viral persistence. So this study here in Nature in 2022 was one of the first studies that I think really solidified this as a real concept. This had a lot of skepticism that the virus could persist. It was thought to be a respiratory virus, which the body clears. We see in this figure, individual persons are lined up in columns, and the days from acute infection sort of march out to the right there, with the longest time period out, being 230 days, where we still see SARS-CoV-2 RNA persisting to that date. The hash lines indicate a replication competent intermediate form. So we can say that the virus is still replicating even 76 days after infection in one of these participants. So this is a small number of persons. It's an autopsy study. It's hard to get the tissues to study where the virus is persisting. So I think this is a very important proof of concept. This has been sort of covered, so I might skip it, but Paxlovid does seem to prevent in this very large observational trial some degree of long COVID. So when you get Paxlovid at the acute phase, it seems to at least prevent a bit of long COVID, and not just any long COVID, but all the components of it as well. Let's see, I think one slide might be missing there. That's okay. Similarly with vaccines, vaccines prevent long COVID, so I think it's important to note that here in the idea of viral persistence. This is the RECOVER Vital trial. It's explicitly studying whether Paxlovid as treatment can help to fix or treat long COVID. So in this study, patients will get either Paxlovid or placebo plus ritonavir, and different durations, 15 or 25 days. Patients are being enrolled in these different sub-phenotypes that are some of the more common symptom groups of patients presenting with long COVID. This I thought was another interesting study, but maybe I'll skip it. It's a small study showing that vaccine as treatment can actually improve symptomatology. This has been sort of anecdotally in the community and on the social networks, but the group at Yale did study this in a small group and did show most of the patients improved their symptoms after long COVID, and they did some nice immunology work around that as well in this small study. This was a recent study that came out this month that I think ties a lot of the concepts together. It got a lot of press. Some of you might have heard about it recently in the media. But basically, the bottom line of this study from Science was that some of these different pathophysiological processes might be overlapping and sort of tied together through activation of the complement system. So that might relate to coagulation and increased inflammation and tissue injury. So they did some very nice studies in this. I think there are some treatment implications that arise out of this, such as using anticoagulants or complement inhibitors in the treatment of long COVID. One more study that I thought also caught a lot of attention, and it was very nicely done, talked about serotonin reduction in post-acute sequelae after COVID. It proposed this through a viral intermediary in a gut reservoir where some of the processing of serotonin occurs, and showed that it might impair vagal function. So that could relate to some of the neurocognitive symptoms of long COVID. So I think, again, the treatment implications of this are quite clear. SSRIs, might have more effects in long COVID than just on depression or anxiety. There might be some pathophysiological processes that might be at play that factor into the neurocognitive symptoms. This is an earlier study for the pandemic showing just how vast the degree of autoantibody production is during during COVID. This was a study in acute COVID, but there are many, many different antibodies. Some of these are targeting different tissues. Some of them are targeting immunomodulatory proteins. So, we think of this as being, needing to be explored to a much greater degree. And I think Jim's going to talk a little bit about this in his next presentation. So thanks so much, and look forward to taking questions afterwards.
Just go forward, right? Well, there I am. Okay. So I'm going to talk to you. There's a lot of people involved in this work, and a lot of people that have been involved in supporting it. But what I want to walk you through is really how hard it is, what you have to do to sort of dig through one of these mechanisms that leads towards long COVID. It's not a trivial process. So the paper Jason and Helen both mentioned a couple of years ago that we published said that we could actually anticipate who was going to develop long COVID at the time or even before they were diagnosed with COVID-19. And before is because some patients' type 2 diabetes was anticipatory, but very early on, one saw reactivation of EBV, SARS-CoV-2 levels in the blood, and autoantibodies. Now, the challenge with these is that those are crazy, there'd be great diagnostics if they lasted, but they don't last. They're very transient. And in fact, when one of the well-known people in this field, Akiko Ayazaka, we were still working with her to look at autoantibodies late in the game. And she said, we don't see them. But all her patients were like at 6 months post-diagnosis. And if you look, here's patients' autoantibodies over a 2-year period. They're there for about 3 months, and then they're gone. Okay? But we know autoantibodies, if you had them early in the disease course, you're very likely to have long COVID months later. If you had them early in the disease course, your risk of dying from COVID-19 was higher. And so we wanted to track this down. And one hypothesis that we had that really came out of the lupus literature was that, is this a pointer? Okay. There's this, normally what happens, when B cells are the things that produce the antibodies. And so when they get, triggered by the signals from an infection, they'll migrate to germinal centers, which are in solid tissues, and mature with the help of T cells and other immune cells, and then start producing antibodies. But in lupus patients, and it turns out in almost everybody, it's just they were first seen in lupus patients. They were thought to be abnormal first, but now they're just less common. You can actually have B cells that will mature without all this help. They're called atypical memory B cells, and they will begin producing antibodies. And we saw in the patients that were producing autoantibodies that these cells were elevated. And so to study this, it's really challenging. These are rare cells. And there's a lot of confounding factors that can influence such a study. So we selected for women, they have higher antibodies in general, and their risk of PASC is higher, long COVID. These were elderly women, but in particular, they were actually of a very narrow age range. And so two major confounding factors are just gone from the study, age and sex. And we only, out of 209 patients we started with, this gave us about a dozen patients. They had very similar levels of atypical memory B cells, these things that we suspect are bad culprits here, but very wide variations in autoantibodies. And so from these patients, we isolated on the order of 100,000 B cells. And in every single B cell, we measured where was the DNA exposed, and what parts of the DNA could possibly be making genes, and then which genes were actually being made, okay? And so this allows us, it gives us a pretty deep view on these B cells and allows us to ask, if you're making autoantibodies, if you're not, what's different about these B cells? And it turns out there's a lot of things different, and it explains why something like vaccination or molnupiravir is actually important in lowering the risk of long COVID. Number one is that you have elevated DNA, RNA, viral-like sensors in these, basically these B cells are being cranked up by signals. It could come from tissue damage, but probably coming from virus as well. And so getting rid of those virus signals early in the disease course or being vaccinated to keep them down is important. Second is that these cells, so these are the autoantibody levels. So these are the high patients are over on the left. And these cells actually get cranked up in terms of secreting things. And on top of that, you can actually identify really fundamental transcription factors that are driving them. I'm not going to worry about too much what that means, but it says if you really wanted to dig into this data and find a drug target, you probably can. So we actually took from these patients, we had a little bit of biospecimens left, and we matured all the different types of B cells into, if we could, into antibody-producing cells to see what happened. And it turns out these atypical memory B cells pretty much exclusively make autoantibodies. The regular B cells make both antibodies and autoantibodies. But overall, if you have a B cells that are making a lot of autoantibodies, your immune space is less. You're just making less antibodies. And so your ability to recover from that disease is actually slowed. And the fact that you actually have B cells in the normal pathway that are making autoantibodies suggests that there might be a recall response here, that these patients may actually have had this before, it just didn't affect them so profoundly as it did here. We don't know that for sure. So what it tells you is that these B cells, they're actually supposed to be there, but and it's probably a normal response. They're having viral and other types of signatures that are cranking them up. They're just trying to make antibodies really quickly. And it's like, let's just make as many antibodies as we can and live to fight another day. As a consequence, you make a lot of antibodies with lousy properties, and they're cross-reactive. And what that suggests is that it's not just these lupus autoantibodies that should be high in these patients. They should be making antibodies against the whole human proteome. And in fact, they are. And so here's these autoantibody high patients, and we measured the autoantibodies against this number of proteins, the antinuclear, antisystolic, membrane, secrete, every single class of proteins you can do. They're all high in these patients. And so when you ask, how do you get so many different symptoms? How do you exacerbate all these maybe underlying symptoms to make them elevated? It's because a lot of these autoantibodies are going to be functional, and they're going to be impacting your health going forward. So even though they may disappear quickly, like in 3 months, not really quickly and quickly, but they can have a lasting impact. And I think that that's probably what we're seeing in these patients. Now, this is not the only cause of long COVID, but it's a pretty big one. And so you see these are we believe it's some sort of a survival response against SARS-CoV-2. And it's triggered by these viral tissue damage signatures that you can absolutely repress through things like vaccinations and antivirals early in the disease course. Antivirals late in the disease course, I don't think they're going to help that much. Autoantibodies have serious health consequences. We know they can impact the rate of mortality. And I know Akiko has tried some of these autoantibodies in animal models, and they cause all sorts of interesting phenomena, so they're functional. Not all of them, but some of them. Some patients exhibit evidence of this antibody recall response, suggesting that perhaps some patients just have a tendency to make these autoantibodies. And in fact, we actually have early evidence that autoantibody production may have underlying genetic factors. And we don't know, there's actually a pretty clear signal, and it's the same signal that you would say is a risk for type 2 diabetes. But I'm guessing there's just overlap in those two types of polygenic scores. That is, they're not actually anticipating the same thing. And with that, thank you. And I guess we now have the panel. We have the questions.
I'm going to go ahead and ask the speakers to come up and sit at the desk. And then we are a little bit behind, but so thank you all for speaking. I think it was actually really informative to go in this particular order and go from public health and the broad lens down to the autoantibodies. And so there are a lot of questions that came in from before the session, but I think what I'll go ahead and start with is maybe just your thoughts on if you had to sort of pick the one thing that you think is the biggest unmet need for you and your teams in particular that you would like to see addressed to be able to work on this ongoing pandemic of long COVID, what would that be? And I'll give you guys each about a minute. Tao, do you want to start?
More resources do the data and surveillance work really our state. A couple of people, but a lot more work needs to be done to know how. Counting the population. Lives, but on a population level. More sources for surveillance, I think, would certainly help us better understand the population health.
Eric?
The importance of ongoing layered approaches to mitigate COVID-19 that's real, still here, still a threat is really important. And additional resources will go a long way in order to be able to do that work, be there to be that liaison, build trust that will not only work for COVID-19, but all the other public health work that we're trying to move towards.
Yeah, I think I'll try to answer this question a little bit with my clinician hat on. So I'm a practicing infectious disease doctor at Swedish Medical Center, and I do see long COVID patients in my clinic. But I have to say that there are a lot of providers. I think maybe Dr. Friedly mentioned this just about not really believing the syndrome exists. And, I think by the time patients get to me, they do seem quite overwhelmed by having what they've gone through to get to a provider who is going to actually, look into long COVID and take those symptoms seriously. So I do think we need a lot more education of our medical teams, our medical partners, help build out referral networks. I think this AHRQ grant is a great step in the region towards doing that. I think I'd love to see the federal government and other players speed forward some of the trials. We need more agents in trials so that we can get tools into clinicians' hands. I think that really changes viewpoints. Another common viewpoint I hear among my colleagues is, well, what can I do about it? So I think that having biomedical interventions that work against some of these posited pathophysiological processes is really important, and we're moving towards that, but it has been a slow process. So I'd like to see that accelerated as well.
Well, you stole my answer there. So, so I would agree with all of those comments. But I think additionally, in addition to the clinical trials where we can translate the results of all of these studies that have been wonderful at pointing towards pathophysiology, we need to have those translational studies and clinical trials to be able to give us some, additional treatment data on what are the most effective treatments. But I think beyond that, we also need a diagnostic test, and we need a clear definition. And I think those are things that are in the works. But I think that's from a clinical standpoint, that's what I really need in the clinical side, because I think that will go a long way for to be able to improve surveillance and to be able to have something that's available to patients to be able to document their long COVID, and that will in turn help with some of the disability issues and return to work issues that we're seeing as well. I know that Nikki's going to talk about access to care and primary care, so I'm going to let her do that.
You know me too well. It's funny, as you get to the end of the line here, you always want to agree with what things that everybody else said. And yes, the one thing that I will expand on is that in addition to awareness in the medical community, I think awareness of this condition in the general public, there are so many areas outside of Seattle and in other parts of the country that people do not believe that this is actually real. And there's a lot of gaslighting, not just from the medical community, but also patients' families. And so that's what I wish. I wish that there would be just a general knowledge, just awareness. And then the other thing that I would say is, from a system standpoint, is more support, particularly on the primary care side. I'm sorry, you just cannot see these patients in 15-minute visits. It's not fair. It's not fair to me. It's not fair to them. And, it's not all about making money in my mind. And we really need to be supporting our clinicians that are actually supporting these patients. That's the only way that we're going to actually move forward with this in a team-based approach.
Well, I think, one of the reasons why we're excited about pushing this field forward is I think it actually is beginning to shed light on chronic diseases in general. And I think that's actually a really big deal. And it goes beyond it helps go beyond the sort of COVID-19 fatigue that, you go to Congress, there's fatigue. You talk to people, there's fatigue. But you talk to people about chronic conditions, there's not fatigue. And there's a real appreciation that we don't have effective treatments. Basically it's go get more rest and call me in the morning kind of thing. And what we've learned during this pandemic is that looking at specific chronic or whatever acute event happens that leads to chronic conditions, seeing that timeline develop with a high level of resolution is crazy important. And having patients that are willing to come in and give their blood every month for a 2-year period after such an event, I think is going to be transformational. Right now, the fact that we're several years out, we don't even have a diagnostic. That's crazy. But it's actually, once you begin looking at what it takes to understand these diseases, you understand why it is so hard to get a diagnosis. All the signatures of the disease that would be great, just gone. And you're going to look at other things, and the heterogeneity of disease late in the game is difficult. But nevertheless, I think that's the way to really understand this condition, is to actually treat it as a chronic condition along with other ones, and say we're actually going to really solve what I think is probably the biggest challenge of medicine this century.
Okay, great. I think a lot of the questions that were asked ahead of time were answered in your talk. So I'd like to actually just open it up to the audience and see if people have questions for the panel. And if not, I have a list. Okay.
Thank you. My name is Gauri Sivarajan. I'm one of the anesthesiologists at UW here. I have two things to say. One is just something that that kind of bothers me. When you talk about awareness among the public and awareness among the physicians, there's very little awareness of long COVID clinic among the physicians at UW that I work with. Most of my colleagues have never heard about it. Even the ones who've had COVID and have had some at least immediate bad symptoms have not heard about it. Many of my friends in the community haven't heard about it. So my daughter has long COVID, so she's registered with the clinic. So I know a little more about it and I try to spread the word. I think it's worth spreading the word around. Okay, the other thing is I had a question about the autoantibodies. Is there any way to test for it?
Yeah, if you do a normal autoantibody test, typically they give you a yes, no, and that's the kind of thing that's done for SLE patients. But if you ask for a quantitative autoantibody test, it'll give you the same panel, but it'll give you a quantitative answer. And many of these patients, the levels are significant, but they're subclinical, meaning they're not, flaming lupus. And so you're asking for a quantitative autoantibody panel of anti-nuclear antibodies and interferon will give you that answer. That's a standard lab that I think LabCorp or places like that will do.
Thank you. Anybody else?
I would just like to comment on that. In my joint faculty role in lab medicine, part of what I do is try to improve lab stewardship and making sure that people are ordering labs when they are indicated. And I have to say that until we can actually find a diagnostic test that's actually going to change management, I would encourage people not to be ordering autoantibody tests on everybody that has long COVID. Not that.
Yeah, I agree. I
Not
agree
that
with
that's
you.
what you're saying, but I do just want to make that clear. Because I do have a lot of patients that come in and ask me to order a slew of lab tests, but really it's not going to change our management because we don't have anything to treat with. And we know there's a dysfunctional hyperimmune response going on behind the scenes. So until we actually have a way to treat it, yeah.
Can I add one point to that too? I think a lot of what we have available to us as clinicians in our toolkit is limited, and we don't have a lot of clear answers. Since I've participated in big study that Jim mentioned, where we did see that autoantibody elevations were a very strong predictor of who's going to develop long COVID. I have sent a lot of autoantibodies in my own clinic. They are available, through regular clinical labs, and I've had a little bit of a disappointing experience with that. But I think it's been very interesting because it's led to other autoimmune diagnoses. So sometimes this idea of an unmasking is kind of what our initial data sort of suggested, that people who had low levels of underlying autoantibodies had a prediction to develop long COVID later. That seems to be an unmasking phenomenon in my kind of anecdotal experience, where I've made lupus diagnoses, polymyositis diagnoses, and other things in patients who have some of the symptomatology of long COVID, but it might actually be due to another process that was unmasked at the time of COVID. So I think some of this idea of referral to specialists in long COVID settings is very important because there might be other biological processes going on that we don't know about. And, my general approach is to, follow the patient's symptoms and think about diagnoses that might or might not be long COVID with those symptoms. So that's sort of the tendency I take. I don't send the panel on everybody, but I actually do send, the SLE panel, like the basic screening labs on everyone, which tends to sort of start to lead in different directions. So that's, the tact I've taken in clinic. I think it gets a little bit trickier in, trying to decide what therapies to give because we really don't have the data about how to administer treatments in long COVID. So, my personal tendency is a take no harm approach first with treatments, but I think for workup, I'm a little bit more lenient to sort of explore based on symptomatology.
I'm with you. I order ANA all the time, but I also know how to counsel about it. And I think I should clarify by saying if you're going to order the test, then you should know how to address the
Exactly.
result.
Yeah.
And so often what I see is that there may be a positive ANA, for example, and then a negative reflex panel, and then people get automatically referred to rheumatology. And that is what I mean by practicing good clinician stewardship, and that not over referring and like knowing what you're ordering and how to counsel on the result and what you're doing with the result. Otherwise, you shouldn't be ordered.
I just wanted to thank you for your comment about raising awareness because I think that's so important. At the Washington Department of Health, we have the Power of Providers initiative, which was launched to promote COVID-19 vaccination amongst healthcare providers. And recently, the group has begun to pivot some of their work, and we're very grateful to Dr. Friedly and her team for collaborating with the Power Providers Initiative to provide free webinars they're aimed at healthcare providers to help them to promote awareness of long COVID and to give some of the basics in terms of diagnosis and a framework for treatment. But I totally agree. We definitely need to do more public messaging, more messaging to healthcare providers, more messaging to the public, more messaging to disadvantaged communities and linguistically and culturally appropriate ways so that the message gets to everybody in the state about what long COVID is and how to seek help.
I think we have time for one more question. So
First of all, I want to thank you, Helen, and all of you for doing this symposium. I'm Judy Wasserheit. I'm in global health and infectious disease here at UW. And for me, one of the most interesting and exciting things about what's going on with respect to long COVID is that we've known for a long time that there are long-term sequelae of a whole range of infectious diseases, particularly viral infections, but also some bacterial infections. And I think there's an opportunity to start to understand more broadly, rather than just looking at, long COVID, just this whole range of mechanisms. And my question is what in the RECOVER trials or studies or in other research that's going on, what other pathogens are being looked at in terms of these long-term sequelae and mechanisms? And could you say a little bit about what you would like to see in that area? Because I think there's a huge opportunity here.
I'll start. It's not happening in RECOVER, but I think one of the best things that one could imagine doing is to do a side-by-side study with something like Lyme disease, where you also have an acute event and you can follow over time, or mononucleosis for that matter, or things like that. In RECOVER, we certainly are taking pretty comprehensive patient histories. We're, doing the longitudinal studies that you would want to do. And we have enough people in that study, I think 27,000 that we've fully enrolled, that one will be able to, just by coincidence, you'll be able to look at multiple disease conditions overlapping with long COVID. So I think that kind of stuff is possible, but it depends on the resolution of what you're after. So from an epidemiological point of view and with some biomarkers, I think that will be covered by Recover. I think to really dig down into the mechanisms, I think you need to have very well-defined cohorts for something like EBV and COVID and et cetera.
Great. Well, thank you everyone for coming today, and thank you to the speakers for talking to us about your research and your work and your advocacy. We have refreshments upstairs, and I think we'll all be around for a few minutes if you want to come up and ask any questions. And thank you for coming. So.
Yeah, of course. Thank you. Goodbye, everyone.